am working at the Semmelweis University as an internal medicine specialist and as a gastroenterology fellow, and I'm also a PhD student here at the Central for Translational Medicine. And my vision with my scientific work is to reduce mortality and morbidity related to pancreatobiliary disorders. And my mission to make this vision a reality is to enhance different endoscopic interventions used in the management of these disorders. And to achieve this, I am currently working in two specific projects. The first is about the role of different ERCP techniques used in patients with previous Roux-en-Y gastric bypass operations, and in form of a systematic review and meta-analysis. And the second project would focus on the endoscopic management of ward of pancreatic necrosis by conducting a clinical trial. So let me introduce the first one. As it can be seen on the slide, Roux-en-Y gastric bypass operations, which are bariatric surgeries, create a very difficult anatomical situation for endoscopists when the investigation of the bypassed organs are required. For example, an ERCP is required in our case. The three most common ways to perform an ERCP in these patients can be seen on the slide, with the first two figures depicting the two current standard methods, the laparoscopy-assisted and enteroscopy-assisted techniques. And the third one demonstrating the newest technique of the three, the so-called EDGE procedure, which is named the endoscopic ultrasound-directed transgastric ERCP. Which one is better than the other, which one is safer than the other, it's still a question open for debate, so we aim with our study to clarify these uncertainties. We formulated the question whether there is any difference between these ERCP techniques in Roux-en-Y gastric bypass population regarding safety, feasibility, and clinical success rate. We used the PICO framework where we search for primary outcomes like technical and clinical success rate. Technical success rate defined as the rate of successfully reaching the papilla of Vater, and clinical success rate defined as successful completion of the planned endoscopic intervention. 67 studies were included in the final analysis with more than 2,200 patients, and my dear audience, let me introduce you the results of our analysis, starting with the forest plot, presenting the proportion of successful access to the papilla with each type of ERCP techniques. Well, reaching the papilla of Vater is a crucial part of every ERCP procedure, but this is exactly the step which gets very difficult in these patients due to the previous bariatric surgery. And I think that assessing the rate of successful intubation of the bypass duodenum is a very important aspect when assessing the feasibility of these techniques. After all, our study is a feasibility study. So we used proportions with 95% confidence intervals as outcome parameters, which yielded in numbers between 0 and 1, where 0 stands for no success and 1 means that all of the procedures were successful, in this case in terms of reaching the papilla of Vater. So our results suggest there is a 78% chance to reach the papilla with the enteroscopy-assisted technique, while it's 93 and 96% for the other two techniques respectively. The difference between the subgroups were statistically significant. It has to be added that only retrospective studies were included, but between study heterogeneity was not important. So we think that our results are clinically relevant due to the fact that enteroscopy is still the most widely available, widely used endoscopic modality in most centers around the world for patients with surgically altered anatomy, but in our analysis it yielded the poorest results. When we look at the second forest plot, which represents the clinical success, defined as the rate of successfully carried out ERCP procedures by each technique. And we can see that the significant difference between the enteroscopy-assisted method and the other two techniques grew even bigger. why the heterogeneity between the studies remaining unimportant. So I think its relevance speaks for itself, but when we look at the first forest plot, then we can see the proportions of overall complication rate, which is also a very important outcome for our study, because enteroscopy-assisted ERCP has been associated with lower adverse event rates compared to the other two. So it is supposed to be the safest but the least effective. But our results suggest that although enteroscopy yielded the lowest adverse event rates, but the difference between the groups didn't reach the level of statistical significance. As you can see, that P is 0.34. So our study has some strengths. I would say we implemented a very strict inclusion criteria when selecting the patients. That means that every patient received Roux-en-Y gastric bypass operation, and this type of operation only. So no other types of bariatric surgery were accepted, no other types of Roux-en-Y reconstruction were accepted. This is also true for the endoscopic interventions. That means that no other upper GI endoscopies were included in the study than ERCP. Also, a great deal of attention was paid on the statistical independence of data, which means that for every patient, only the results of the first intervention were included in the final analysis. Naturally, the retrospective nature of the included studies and the indirect comparison used lower the level of evidence and limits the power of our study, and probably the variation of expertise among the endoscopists influenced the outcomes of the studies included. So as a conclusion, I would suggest that the role of enteroscopy-assisted ERCP in patients with previous Roux-en-Y gastric bypass operation is at least questionable. We can formulate other conclusions, like there is no significant differences between the complication rates contrary to the available data from previous studies, and EDGE as the most newest of the three techniques is a safe and feasible ERCP alternative. For the clinical implication, I would say that EDGE should be preferred. EDGE and laparoscopy-assisted ERCP should be prioritized over enteroscopy-assisted technique. And as for the research implication goes, in general, prospective studies are needed. But for example, factors influencing the EDGE procedure or cost-effectiveness analysis were also a great idea. So I am finishing my risk of bias assessment soon, and would like to continue with my second project, where we would like to focus on the management of ward of pancreatic necrosis by comparing two endoscopic treatment strategies. Ward of necrosis is a local complication of acute necrotizing pancreatitis, which basically means a mass of necrotic tissue with a well-encapsulated wall. And under certain circumstances, it has to be treated, preferably via an endoscopic method, which generally means the entering of this necrotic cavity with an endoscope and performing a necrosectomy from there. And this entering of the cavity should be done via a metal stent from the GI lumen naturally. But how this necrosectomy should be done exactly, when it should be done, how, and these are still unanswered questions. And we would like to perform an investigation, possibly a randomized clinical trial, where we would like to enroll one group of patients into a treatment arm where the intervention, that means the necrosectomy, would be performed in a regular basis, and in the other group it should be done only in an on-demand fashion. But again, this is in the planning phase. The primary outcome should be the composite of major clinical complications in non-inferiority settings. So I would like to finish my talk with thanking you for your attention, with a quote from Mark Twain that you should be careful about reading too many health books, as you may die of a misprint. Thank you very much.
Which method is more cost-effective from the three?
The least cost-effective is probably the endoscopy-assisted technique from the point of view of the intervention. But when we look at the higher hospitalization rate, which is in general associated with the endoscopy-assisted technique, then probably this cost-effectiveness analysis would result in another sum. So again, as for the investigation itself, definitely the endoscopy is the most price-worthy.
And another question about EDGE. Is there any experience in Hungary with EDGE?
As far as I know, there are no experience.
No? You're talking about the overall complication rate or chance and the papilla converting or reaching the papilla. Any other outcome? Did you investigate?
We investigated a few more outcomes as well. For example, adverse events rate in detail like perforation, bleeding, post-ERCP, pancreatitis. Perhaps I will present the forest plots about them in our next presentation, but as far as I can say, the difference between them is not statistically significant, but for the sake of time, I could not include them all.
Have you decided yet on the primary outcome of the proposed randomized control trial you are planning?
To be honest, Bálint, I have not yet, but I've thought about it. So when we choose the non-inferiority setting, then the major complication rate, adverse event rates would be the best.
Okay, thank you.
When we reach a 60% reduction in adverse event rate with a 90% strength, that would be, I think, a great investigation.